All right. Well, thank you so much, everyone, for joining us today for National Ovarian Cancer Coalition's Ask the Expert series. Today, we are joined by Dr. Koch, who is an endocrinologist at Fox Chase Cancer Center. And he joins us today for the conversation about ovarian cancer treatment and its effect on our bones. So thank you very much, Dr. Koch, today for being with us. We really appreciate your time.
Thank you very much. It's my pleasure.
Wonderful, wonderful. So let's just get started and have a conversation about bones and treatment. So just to kind of get us started for the conversation today, the goal of our program today is to really provide an overview to our audience of how to maintain bone health while undergoing cancer treatment. And so could you maybe just start briefly by talking to us a little bit about how someone who has ovarian cancer and is in treatment, how that might affect their bones and why they should be paying attention to today's program, why it's important for them?
Sure.
Great.
So depending on your age, I mean, if you are a woman in menopause already or before menopause, plays the first role, because you still would have sex hormones, and sex hormones are extremely important for bone. And then when you undergo treatment for ovarian cancer, for instance, let's say you have one of those germline mutations, BRCA1, BRCA2, and you might decide, well, okay, I want to do, because the chances for ovarian cancer is like 50%, have my ovaries removed. Within a year after that, if you're a premenopausal woman and have that done, you lose a dramatic amount of bone already measured by T-score. So just by having the surgery alone. They compared this, there's not many studies, one or two or so what I'm aware of, with hormone treatment after that, female hormone replacement therapy. So after you had the ovaries removed, and that can protect your bone loss. But if you don't do that kind of treatment, I mean, you will lose 7% or so. I mean, it's measured in T-scores of bone. So if you are a woman who is in menopause, and has been diagnosed with ovarian cancer, and then you need to undergo a variety of treatments, including, say, chemoradiation or just chemotherapy, that also affects bone health by basically stimulating osteoclasts, which are the cells that resorb your bone cells or bone, and damaging osteoblasts, the bone maker cells. So you might have a double jeopardy here. If you get radiation, it destroys basically your bone making cells also, including some vascular damage. So you have bone supply issues, from the respective vessels, depending where the radiation is. Often, if you have ovarian cancer, it's to the body area. So it could be a sacral problem, it could be a hip fracture. We see that also with cervical cancer, like in a couple of % of such patients who had radiation. And then most importantly, what I started out with, chemotherapy might cause hypogonadism if you're a younger woman still, who would have hormones produced like estrogens from the ovaries. In such case, that's a big risk factor for bone loss after and during treatment of ovarian cancer.
So in essence, chemotherapy can cause the bone making cells to not work properly. Therefore, you have bone loss. Is that what you call osteoporosis? Is that the same thing?
Yeah. And so chemotherapy, I mean, of course, you might say what kind of chemotherapy you're getting, but generally speaking, I mean, during chemotherapy, there's more severe chemotherapy that makes you feel as a woman very ill, and you get concomitantly high dose steroids like dexamethasone. And those steroids are also basically bone-eating cells. They're catabolic. I mean, it's like, a little translation thing. Ana in Greek means up. So that's usually a good thing in many cases, and kata is down. And they are catabolic. They're not just bad for bones, they're bad for a lot of things if they're in high dosage. So it's all about homeostasis. There's a reason why bone cells, they are osteoblasts, maker cells, and then also resorbing cells. That's basically to keep the bone in homeostasis. And one other factor is the older we get, so one factor we cannot influence much, and we don't really want to do that, is aging. So the older we get, the more osteoclastic activity the bone shows, meaning you have also a decline in bone mass, in bone making cells, in osteoblasts, are less active. If you are also yourself less active, like immobile, not moving much, you're stressed, you feel tired all the time from the chemotherapy, and many other factors can influence that. That's additional risk factors for bone loss.
For bone loss, yeah.
Just not the chemotherapy alone, but the sequelae of the chemotherapy.
Exactly, exactly. And that's one of the questions I was going to ask, and I think you kind of mentioned it already, but what types of treatment someone's going, who has ovarian cancer might be going through could help, could cause bone complications or bone loss. You talked about chemotherapy, you talked a little bit about radiation. I know those with ovarian cancer don't usually have radiation, but what about hormone therapy for that small amount of people who have hormone therapy for treatment? Can that also, you mentioned steroids too, but can hormone therapy cause bone complications?
Yeah, I mean, steroids, generally speaking, if you use if you don't use them as a replacement, of course there's people who have concomitant diseases, like they have adrenal insufficiency and they need maybe a steroid replacement therapy. That's different than giving steroids for a chemotherapy or for a cancer,
right,
which is high dose, usually dexamethasone, a very strong steroid that can cause bone loss. Okay. And then if you need it after certain cancer types, now you needed, say, aromatase inhibitors. We know that from breast cancer patients. They block the action of estrogen, you have the female hormone, and that is associated with significant bone loss during the first year.
Mm. Yes, so, we actually had a question. Yeah.
So if you wanna know, so what would we expect for, let's say, a woman who does not have any more female hormones? So say the ovaries are gone, or you are in menopause and the ovaries are not working. Anyways, for that matter, and then on top you get ovarian cancer. Yeah. So you lose on average 1 to 3% of bone per year, physiologically. So
just naturally.
That's just a natural bone loss from not having any more female sex hormones. So if you then have other factors contributing, like we talked about chemotherapy, aromatase inhibitor, that adds to that percentage of bone loss annually. Yeah. And then, of course, how do we assess that? I mean, we assess that whether you get a fracture that has really not a major trauma. So we call it often a fragility fracture. Not doing anything and you fracture the bone. And then, of course, fractures also can occur in people with normal bone strength and health by a trauma, if you really have a severe fall. So, I guess one of your other questions was, how do we work on that? So the number one thing is, and this chemotherapy also might get neuropathy. So you have less sensation in your feet, and then you might get balance problems. Yeah. So you really should work on fall prevention, because any fall, even if you have strong bones, can cause a fracture of a bone. Right. So that's another thing. Indirectly, chemotherapy and neuropathy, you have less proprioception on your feet. I mean, the feeling is basically not as strong, and then you trip, you fall, you fracture a bone. Right.
So one of the main things that we really want to watch out for is those bone fractures, which can happen for those that naturally don't have the hormones because they've had their ovaries removed or they're in menopause, or on top of that, the treatment. So yeah, that's definitely something we want to watch out for and not cause, right?
Yeah.
So what are things that people maybe can do to prevent bone loss if they're on treatment? Is there anything that they can do to kind of help minimize the bone loss?
Yeah, I mean, there's a few essentials. Of course, the number one thing I would say, since we talked about falls, is to really work on fall prevention. So there are some exercises to basically strengthen your balance. So, I mean, you might find this a little funny, but when you're kids, I mean, you're jumping on one leg, it's like these exercises you do to test your physical activity and, those kind of things. And that's what we would have to do, fall prevention activities or exercises, so to speak. And the next thing is to assure you have enough calcium and vitamin D supplement. It does not mean necessarily that you have to take these tablets. And lots of people might say, oh, no, 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 you need to take 1,000 milligram, or depending on age, 1,200 milligrams of calcium a day, elemental calcium, plus vitamin D, 800 units, some say 1,000 units. I say it really depends what you are eating. Because if I measure the vitamin D level, and that's one thing also that helps the prevention, and your vitamin D level is okay, and you're not taking a supplement, but you eat right. And that's, of course, now the question. If you get chemotherapy and you lose your appetite and you eat no longer right, then you actually might need a supplement. So, I mean, it all needs to be factored in the individual patient, not as a general thing. And the same is true for calcium. Some people love milk. Some people cannot have it because they have problems with, digesting or, accepting the milk. So that's another factor. And there's the third one, like we talked about exercising. So it's fault prevention, making sure you have enough calcium and vitamin D in your nutrition, or supplementation if not appropriate nutrition. And then, have enough exercise, including balance exercises. So anything, and this is another thing, we know is if you don't put gravity on the bone, so those people who are bodybuilders and, exercise their muscles at the same time, they exercise their bone and get very strong bones. I wouldn't advise, though, to take too heavy weights in someone who hasn't really, who's not adjusted to that, because then you might fracture a bone. So it's called, back to what we said. I mean, you need to have some adaptation, to get used to that. And, so maybe if you're just diagnosed with ovarian cancer, I guess that was your question, Jennifer. Then you start early thinking about, okay, am I at risk for bone loss? Have I been lazy all my life with exercises? Do I need to get a little more active now? Because I will lose, I already probably have, without knowing, but I probably have already a lower bone mass. And I need to get on it now before it's too late, because I will get more tired during the therapy, and I will definitely lose more bone. God forbid, I mean, I don't get enough calcium, vitamin D, and God forbid, I mean, I fall, just a minor fall, but then I fracture a bone. And once you fracture the bone, you become more immobile, and you have more bone loss from that time period. Right. So that brings us to the question, what if you were diagnosed with bone loss that is called osteoporosis and then in need of treatment?
Mm-hmm.
I mean, if you want to ask me that question, I mean, I would say, well, okay, if you are a cancer patient, I would not consider an anabolic therapy, because usually there are growth factors. Growth factors, you want to make cancer grow. So you usually aim at anti-resorptive osteoporosis therapies, and that's usually a group. They're called bisphosphonates or the denosumab. These are the major two anti-resorptive osteoporosis drugs we have. There's also anabolics, they're injectables, but of course it also depends where your bone loss then is.
Yeah, I was going to ask you about bisphosphonates. I've heard that term before for some women who I've talked with who have been on treatment and they were prescribed a bisphosphonate. Can you explain what that is again?
Yeah, well, bisphosphonates is an anti-resorptive group of medication. That is the oldest one, pretty much, we know, around for decades. And in the old days, I mean, people were basically punished by taking such a medication once a day. Then it was designed, it's called alendronate, for instance, it's one of them, once a week, better. Then people had the idea, how about once a month? Okay. Then we came out with intravenous injections. And why would that be? Because some patients had problems, with the absorption or side effects like heartburn. And so they said, I really don't want to take a pill, whether it's once a day, once a week, or even once a month is too much. I'd rather go to an infusion. So we then, not myself, but the bone people basically found out about infusible bisphosphonates. And one of the most frequently one used now is called zoledronic acid. Also, I mean, I don't know if you can say a trade name. There's two different ones. It's reclassed, and there's also one. It's called Zometa. What's interesting about that is that these substances are not only used for osteoporosis treatment, but also for bone metastases. In a way, you might say and think, well, if you are treating with those medications osteoporosis, does this also have an effect of preventing bone metastases in such patients? And guess what? Indeed, it's been shown not only for breast cancer and other cancers, including also I'm treating thyroid cancer, that bisphosphonates improve survival of patients with bone metastases from a variety of cancers.
I know bone
ovarian
metastasis.
cancer.
I know bone metastasis for ovarian cancer is fairly rare, but that's good to know. That's really good to know.
Yeah, it's good. It's good to know, just not to put the angst, out there, but to say there's another positive effect. I mean, let's just say, I mean, if you did have a mutation in BRCA and you're also at risk for breast cancer, for instance, I mean, just to have the whole picture, because sometimes when you have one type of cancer and you test genetically, you might also be at risk for developing many other cancers, depending on that individual mutation.
Sure. I see a question coming in, if you don't mind me asking here, since we're on the topic of estrogen. The question is, can increased estrogen reverse bone loss?
Increased estrogen.
Increased
that's an interesting question. The question really is, what is an increased estrogen?
Yeah, sure.
Yeah. So, I mean, because there's a wide range, what is considered a normal estrogen, I mean, basically, and then for estrogens, there's different types. There's estradiol, there's estriol. But I mean, let's just say if we replaced a woman in menopause or after treating ovarian cancer with female hormone replacement, then we usually give estradiol. That's the estrogen we are usually choosing. And it could be a tablet. A tablet has usually a little more effect on the liver, and also for the clotting factor. So usually, maybe the better option is transdermal, once or twice a week. And if you replace a woman with that, of course, I usually say, no matter what we choose as a hormone or as a medication, usually maybe the lowest possible dose that shows an effect. And then titrate up. Some women, I mean, if they don't have enough estrogen anymore because they have no ovaries, might develop hot flashes, or those women who take an aromatase inhibitor, severe hot flashes. And of course, now with those who have to take those substances, you don't want to really like you called it, over-replace estradiol.
Over-replace,
I mean, that's would be contradictory, because on the one hand, you try to block estrogen action by giving such a substance like an aromatase inhibitor. On the other, you shouldn't really give estrogen in such women. But if that's not the case, and you really truly can, in an ovarian cancer woman, replace the hormone, then there shouldn't be a problem. I mean, you should titrate. I mean, my recommendation would to titrate that to the symptoms. If there's hot flashes, I mean, that's one benefit, that the hot flashes, the vasomotor symptoms might go away, but certainly it has good bone effect. And then there's, even for bone or osteoporosis treatment, the approval of selective estrogen. There's like these modulators, they're called SERMs, and one of them is raloxifene. So raloxifene has a positive effect, not only it's an anti-fracture. So these substances, it's an anti-fracture effect, not necessarily a bone builder, but an anti-fracture effect for vertebral fractures, for hip fractures, and for anything in between. So we need a lumbar spine or hip, so yeah.
Yeah.
So that's and this is also true, and I might add, this is true for these bisphosphonates we talked about, whether they're oral. There's one exception, the ibandronate. Ibandronate, which typically has an effect specifically for the lumbar spine, not so much for the femoral neck or the hip or anywhere in between, so just specifically for the lumbar spine. So that wouldn't be my first choice. And when it comes to that, when you look at, and you assess that by a bone mineral density. Of course, maybe that's not your question. How do you assess that? Well, you got to measure.
Yeah, that was going to be one of my questions, is, if someone is new, say someone is newly diagnosed, that's actually one of the questions that we had that came in, newly diagnosed, how, when should they, what should they know? Like, how soon after starting treatment might someone have bone complications, or how would they know if they had a bone complication?
Yeah. Well, like I said, I mean, since we don't know, I guess I don't know mine, I don't know about yours. I mean, we don't know our peak bone mass, because we didn't really measure our bone mineral density when we presumably healthy.
Yes.
And so most of these women don't know that either. But what we do know from the data is it's within 1 year of treatment. So the first year of treatment, you have measurable bone loss.
Okay.
One of the recommendations to screen for that is to look at the CT, because a CT can give you information about bone health.
Okay.
And or just say plainly, after 1 year after ovarian cancer treatment, it should be justifiable to do a bone mineral density measurement. And maybe earlier, if there's additional risk factors. What are additional risk factors? Like, for instance, heavy smoker, history of heavy smoking, then a history of heavy alcohol consuming. What is heavy? Well, by these guidelines,
of course, yes.
More than 2 glasses of wine a day. I would say that's quite a bit, for a woman, but that's what's been, so then another one would be having another condition that causes chronic inflammation. Usually it's a rheumatoid arthritis or
rheumatoid arthritis. Okay.
A parental hip fracture, that's genetic. And it brings us back to the initial thing. What determines really our peak bone mass? 60 to 80% is genetic makeup, and the rest is environmental, which means physical activity. And then when a woman, for instance, had menarche, if it's delayed, that also can impact your peak bone mass as a woman. But most of that is acquired during the first 25 years of life.
First 25 years of life. Okay, that's interesting. And 60% of our bone makeup, you said, is due to genetics.
Is due to genetics, about 60 to 80%. And unfortunately, that explains when I get this question from women, and they come with a very negative T-score in their bone mineral density measurements. And they say, why is it so bad? I exercise a lot. They do all the we talked about they should do, but they have one problem. They didn't know that genetic makeup. And it wasn't in favor for bone in this case. So, there's not much you can change.
So you could be the best exerciser in the world, the healthiest person, but if your genetics aren't great on the bone front, then there's not much you can do there, huh? Yeah.
Not a whole lot, but you still, of course, try your best.
Of course.
Yeah.
So I know we've got maybe 5 minutes left. I know this time goes by so fast, but I think we've hit some of the main key points about, that, it is something good to know that when you're in treatment that there could be, bone loss, and what you do about it. You talked about some of those risk factors that might increase that risk. I think that's great, what you can do about it. And then some of the things that they can do as far as bone density testing, lifestyle choices. Are there any, this is maybe an odder question, but are there any symptoms that someone might experience that could be due to bone loss that they should watch out for? Or is it when you have that fracture?
Yeah, that's interesting. So it might start with a fracture, of course, as you said, could be, the hip, for instance, or a vertebral fracture. So you might get low back pain. And then if you just sit there and then boom, you have suddenly shooting low back pain, you might say, I just, pulled something, and after a few days, it's not going away. Maybe a recommendation should be to really investigate, do an X-ray. I mean, I had a patient today who told me she got a spontaneous rib fracture just by getting out of bed.
Oh, sure.
Just turning, get up in the morning, get out of bed, boom, have some pain here, get an X-ray, it's a rib fracture. Right. So things like that can happen. That would be a symptom. If you have chronic low back pain, most of the time it's degenerative disease from the discs. But I might add, if you think about the bone and there's a microarchitecture and you have micro fractures there, that's another reason. One thing, of course, you might notice as a woman is you lose height. So if you get up in the morning and you, for some reason, have your measurement in your kitchen and you figure, I can't reach up there anymore. I used to go up there and get my wine glass out. Now I can't. That's one of the signs that you lose height 1 or 2 inches or more. I've seen people up to 4 inches. That's quite a bit from osteoporosis. But pain is
pain. Okay.
Pain
could be.
And then you might be able to help that pain by treating, of course, the osteoporosis. And it's understandable with these kind of therapies for ovarian cancer. There might be many other reasons for getting pain. But one
Sure.
of them could be a fracture
Sure.
in
Absolutely.
bad bones.
We have a question coming in. You talked about bone density testing. What doctor does the bone density test?
Yeah, I mean, usually it depends where you're getting your treatment. I mean, presumably
Okay.
it's at the cancer center. So your respective cancer doctor, the
Okay.
oncologist, OBGYN can order that, but
Okay.
also us, the endocrinologists can order that. And another group would be a rheumatologist. But if you're a cancer center, typically they have a lot of oncologists
Yeah.
there, and they have people like myself, hormone guys, doctors,
Hormone guys.
who can help out with all the hormone questions. And that's how we order the bone density. And also sometimes we have to write a justification letter why we do a bone density earlier than the insurance company might think it should be done. So for instance, usually it's an every 2-year event once you're diagnosed with a problem there. So for a woman who for osteoporosis screening, believe it or not, the age is 65.
Oh, it's 65. I thought it would have been earlier. Okay.
Exactly. If you have risk factors, earlier. And that's why when we talk about ovarian cancer patients, earlier. So you ask these other risk factors. There's risk factors like chemotherapy coming in. You ask these other things about smoking, about parental hip fracture, alcohol consumption, those kind of things. And then of course you can order that much earlier.
Right.
And it can be any of these aforementioned doctors from those fields. Yeah.
Good to know. So that if you're getting your treatment at a cancer center and you've got a good team around you, that's something that they're on the up and up about. Yeah. Okay. Good. I wanted to ask this question because we get asked it quite often. For patients that are in treatment, specifically chemotherapy, the risk is there a higher risk of complications with, we get this question a lot, complications with the jaw and bone loss? We've had a lot of patients who speak to having teeth issues. Is this a bone complication issue? Can you speak to that at all, or does that resonate?
Yeah. Well, it is. I mean, if you do have osteonecrosis, basically dying bone of the jaw. I mean, one should remember that osteonecrosis can happen in many sites. Can happen at the shoulder, can happen at the knee, at the hip. Osteonecrosis of the hip has been associated with high dose steroids, alcohol use. There's many other reasons. The reason why we talk about the jaw often is because that's a lot of bone.
That is a lot of bone.
When you talk about, if you want to learn about bone, you better go to a dental institute because that's where, you can study bone probably best. And that's why we see this effect of osteonecrosis of the jaw with chemotherapy. There's many other things that are done during cancer therapy.
Yeah.
And the problem then is when you have to give a bisphosphonate or one of these anti-resorptive substances, patients are scared. Forgetting that, it's not necessarily that substance that caused it, but many of these other things that already have occurred or will occur during the ovarian or other cancer therapy.
Yeah.
And so when we look at the real numbers, which has been done and analyzed, so say you get a high dose of this osteoporosis medication. And a high dose is in cancer patients when they have metastases to the bone, they get basically in a year a dose what an osteoporosis patient would get in 10 years or so.
Oh, wow.
Yeah. So, and the reason why I point that out, because then you can, and they calculated that recently last year in the Journal of, Oncology. So basically you see there, well, at year number 1, the risk is like less than 1%. At year number 2, it's 2%. At year number 3, it's 2.8%. So it's relatively speaking still a very low risk for an osteoporosis patient alone. Let's just say alone, without all these other chemotherapy and other risk factors, it would be much lower. It would be with an oral bisphosphonate basically almost 0. And if you have an intravenous substance we talked about briefly, it would be 1 in 10,000 to 1 in 100,000. So once patients understand that, I think maybe this can reduce the anxiety.
Sure.
With those problems. And those problems also, the dentist is more scared than the patient
Oh gosh.
You know, and then the dentist tells the patient, you better check with your doctor who, you know, like the cancer doctor or the hormone doctor who says those
Yeah.
things.
Yeah.
And that's why I have something prepared for the patient, and a tool, if patients want to now tune in and look that up. It's the National Osteoporosis Foundation. They have 4 patients, basically a letter designed, and they say in bold, we do not recommend interrupting osteoporosis treatment for dental procedures in patients with high risk of fracture. And they also specify when you should maybe do a pause or when not. I might add this to you also into the audience.
Sure.
These substances, they go into the bone and they stay into the bone. So let's just say if you already had 3 of such infusions, bisphosphonate, and then you develop a problem with your teeth and you have to go to the dentist. Does it really change anything? The substance is already in the bone, you know? So it's when the dentist called, well, we can do the treatment, it's already happened.
Yeah, sure.
And that's something that's often forgotten, you know. So but I mean, there's specific guidelines for that. I mean, with tooth extractions, when you have implants, to take a little bit the anxiety level down when it comes to this jaw problem.
Okay. Well, thank you for talking about that a little bit. We just get that question quite often. So I know that we are putting in our chat below some of the wonderful resources that you have discussed during today too for our audience. And believe it or not, our time is up. So we want to thank you. I know you know, this has been such a popular topic with our patients and survivors, bone issues with treatment. So we really appreciate you taking your time today with us to kind of talk through some of this high level information about bones. So we really want to thank you, and thank you everyone for joining us today, and we'll see you next month.
Thank you very much for everything. Appreciate it.
Sure, thank you. Of course.